Good morning and welcome to the monthly Department of Family Medicine Department meeting. Have a new format. We're going to be doing this every month and not every quarter. We're going to be structuring it differently. So let me just orient you for a couple of minutes to what we're doing and then introduce our program. What used to be the first 15 or 20 minutes of this meeting involved introducing you to new faculty, apprising you of significant events that occurred within the department, and otherwise bringing you news. We're not going to do that anymore. What you'll have instead is a pile of papers in front of you, which include news from the department, introduction of new faces in the department, significant or interesting events such as publication of papers on rural community-based health interventions that involve both members of this department and honorary members of the department who are basically ranchers and farmers and others who live in the community and actually hadn't started thinking of themselves as researchers until recently. All of that stuff is in writing on the papers in front of you, and so you can read and digest that at your leisure. One problem that, well, actually, let me say two things related to problems. One of them is some of you are vegetarians, and I don't know if you noticed, but every one of those boxes out there had meat in them. Panera is on their face apologizing to us for forgetting our vegetarian boxes. They're coming. So you don't have to worry that you're going to faint with hunger before the hour is over. Panera will make you whole before the end of the meeting. Please look at the back of your agenda, this thing that says Education and Training, DFM monthly meeting. On the back, you see an evaluation form. We've been having a low response rate to our evaluations, and it makes it a little bit hard for us to plan, to fine-tune the format of our program. So if you would please evaluate this program, be honest, we can take it. We use that information to help fine-tune what we're doing. And that, friends, is that. We're going to structure the programs that we do monthly now somewhat differently than we have before. We're going to try to actually start the program itself at 12 o'clock, straight up and down. We're going to finish the program at 12:45, after which we will have a facilitated discussion of the material that was presented, questions that you've got, comments that you might have, or otherwise interesting material that follows from the presentation. Today's presentation is going to be led by, or perhaps I should say facilitated by, Kent Voorhees, the Vice Chair for Educational Programs in the department. And he's going to, oh man, I don't know how he's going to do this. Look at all these people lined up here in the front of the room who each have about 3 microseconds to present their program to you. But Kent assures me that this is possible. Kent has a big job because among his responsibilities are all of our GME programs in the department, some of which we have live at the heart and soul of our department, some of which are new additions to our department, and we're working out the interesting implications, values on both sides and so forth. But the point is, there's a lot of new information for you to know and for us to work with around graduate medical education in the Department of Family Medicine. And Kent is going to lead a group, Patty Page, Roxana Witter, Carolyn DiGiuseppe, and stalwarts Dan and John Nagel, whom you already know, are going to basically comment on what's going on in the world of GME and the Department of Family Medicine. So with that, I'll give the program to Kent.
So, thank you. This is going to be an interesting challenge. We've been given the instructions that each person is going to have about 5 minutes to speak. We're going to have somebody even keeping time and potentially shutting us off if we're not done. And then save some time at the end for question and answers. So we'll see how it works. But we do have a lot that we want to talk about and programs that you may not even know that exist within the department. So that's going to be one of our goals. So our objectives for today are to learn more about the new DFM educational programs, to learn about some of the future programs that are being developed, and to learn who some of the people are who are working on these programs. So just first, an overview of our educational enterprise. We're not going to talk about all these today, but just sort of to put things into perspective. And there's some color coding here. So the ones we're going to actually talk about are in red, behavior science is in blue, and established programs are in black. So our residencies, and the names are listed there who are the program directors. I'm not going to go through all those, but as most of you know, we have residencies at the university with the Denver Health Track, Rose, Swedish. New programs in the department are occupational medicine residency, preventive medicine residency. We also have a psychology internship. Fellowships, you may know about some of these and some you may not. Primary care sports medicine, hospice and palliative medicine, rural. Primary care research is with pediatrics and internal medicine. Geriatrics is with internal medicine. And a new program you'll hear about is addiction medicine. John Nagel is working on some fourth-year options for some of our graduates. We also have primary care psychology fellowship, and we have a medical family therapy fellowship in Grand Junction that's an affiliation. Some programs that are in development that you'll hear about are family medicine residency rural training track in Fort Morgan. Working on the possibility of a family medicine residency in Colorado Springs, and we're not going to be talking about those that aren't in red. Health policy fellowship and global health fellowship. We maybe even could strike the possible. That looks like that's going to be in existence with pediatrics. And then part of our educational enterprise includes GME, or the CME with regard to green rounds at Rose, and then a couple of other educational items that we're working on is we've created a professional development committee. We've met once. One of the things we're going to be working on is mentorship and how to train mentors to be better mentors and figure out how to incorporate all of that. We've got actually a long list of things to work on, but we're going to start and work our way through the list. Medical student education. David Gaspar is taking a slow retirement, and so we're actually doing a national search for a replacement. And then program director change at Rose. Brian Bocek has been promoted to associate vice chair for clinical along with Pete Smith, and Chandra Hartman is actually appointed as the interim program director at Rose, and then they're still working on the possibility of expansion of the Denver Health residency. So today's presenters, the presenter will just introduce themselves. We're going to try and have this go quickly so that we actually meet our allotted time. And so first is Patty Page. So to advance it, just push the right arrow.
Yeah. Well, I'm Patty Page. For those of you that don't know me, I am an internist and also an addiction medicine specialist. And I was actually hired about a year ago and to start this fellowship in addiction medicine. And many of you probably are asking why addiction medicine. I spend my life trying to avoid patients with addiction and substance use disorders. And the reason is as follows, okay? There are almost 21 million Americans between the ages of 12 and older that have substance abuse and dependence by clinical definition. And only less than 2 million of these individuals are getting treatment, which leaves a huge gap of 19.3 million people that need treatment but that don't get it. And the public health implications of this disease are enormous. I don't have to tell many of you, just about everybody you see in your practice has been affected by the disease of addiction, and the costs are roughly between 500 and 600 billion a year. At this time, the only current ABMS approved specialty training pathway is through psychiatry and the addiction psychiatry. And recently, over the past 10 years, the American Board of Addiction Medicine has been created, and it was created to develop an alternative for those people wanting to, those demented people wanting to seek specialty training in addiction medicine. And it offers a pathway for people that aren't psychiatrists to develop skills and training in the treatment of addiction. And this is going to be very important because with the passage of the Affordable Care Act, there's supposed parity for mental health, and so there's going to be an extra 30 million people that a certain percentage of those will need treatment for addiction. And it's very exciting to be here at the University of Colorado because there are probably one of the best facilities in the nation as far as thought of as treatment at Cedar, the faculty, and one of the top programs for research and treatment. The Addiction Medicine Fellowship is a one-year program. On February 7th, we received accreditation by the American Board of Addiction Medicine. It is currently a non-ACGME program. However, in conversations with the ABM people, they should be getting their approval in the next couple of years. The training, of course, to enable fellows to care for patients with substance use disorders. They specialize in diagnosis, treatment, and prevention. The core curriculum is going to be, of course, at Cedar, which is right across the street. For many of that you don't know, that has a residential treatment component. Also, we'll be providing education in the outpatient treatment, hopefully at Cedar, in the IOP. There are also a program component in arts with adolescents, and also the STEPS program at Denver Health. The fellows will be trained also in opiate treatment programs, methadone. A longitudinal program has been set up thanks to Corey and Linda at AF Williams in the pain clinic. And we have created, which will about to go into effect in May, the Addiction Medicine Consultation Liaison Service, and we're providing consult in addiction in the hospital. Electives will be available at the family program at Cedar, smoking cessation at Cedar. The Cedar has a very robust health professionals program. The fellows will have opportunity to take elective in that. And the fellows will also have an opportunity to design their own electives. Didactics will be done jointly with the Addiction Psychiatry Fellowship, and we will have a weekly program. And then there'll be scholarly activities. And just lastly, I would just like to announce our faculty. I'm the program director. Our associate program director is Laura Martin. I can't thank Dr. Voorhees for all his help. And the esteemed faculty that we have is with the psychiatry department and also family medicine department. And I just very much like to thank Ann Felton and Steve Millette for all their help with this fellowship. Did I make it?
You did.
All right.
Hi, I'm Roxanne Witter. I'm the program director for the occupational medicine residency. The occupational medicine focuses on prevention of injuries and illnesses in the workplace. We focus on the health of the worker population, do that by surveillance, exposure reduction, and most recently there's a big focus on total worker health, which means workplace wellness, and then other specialized occupational medicine activities. We also treat workplace injuries and illness, and that's through the workers' compensation system. There's an emphasis on return to function and a renewed interest in decreased emphasis on pain management to avoid having people enter into the addiction world. We manage return to work, and we also provide a lot of medical legal opinions in the areas of causality of worker injuries and illnesses, impairment, and maximum medical improvement. The program, our program sits in the Colorado School of Public Health, and then we now also sit in the Department of Family Medicine administratively. Our residents get a Master of Public Health, and they concentrate in environmental and occupational health, and that's usually about 45 credit hours. We're funded for the most part by a NIOSH training grant, and our training center is called the MAP ERC, the Mountain and Plains Education and Research Center. And there's mandatory interdisciplinary training, and in our world that involves training with industrial hygiene, health physics, ergonomics, and occupational health psychology, and those graduate programs sit at CSU. The MAP ERC training grant covers about 75% of our resident costs. It also pays for the MPH tuition and some of the educational travel. There's really very minimal program director support, and there's no program coordinator support. And we're very grateful to the Department of Family Medicine for their support in that regard. We get 25% of the resident costs from other sources like private donations, a small FTE support from the VA, and intermittent institutional donations. So our residency program is funded completely differently than most other graduate medical education programs. Our occupational medicine residents must have a minimum 1-year clinical training in an ACGME accredited institution. About half of our successful applicants have previous board certification in family practice, internal medicine. Sometimes they have a pulmonary fellowship completed. They also come to us from PM&R and from preventive medicine. About half of them have previous clinical experience in occupational medicine, either from military service or from occupational medicine practice, with or without some sort of certification, board certification, and about half of them have MPHs. But they may need additional environmental occupational health coursework. We accept 1 to 2 residents per year, depending on our funding. Our first year training occurs at Denver Health and at National Jewish, and those two sites provide very different clinical experiences. At Denver Health, it's much more the bread and butter musculoskeletal injuries, and at National Jewish, it's more of the illnesses, particularly pulmonary illnesses and some allergic illnesses and miscellaneous toxicology. Our second year residents do most of their clinical training in community settings, either including general occupational medicine practices, specialty occupational medicine practices, and then in some referral practices such as orthopedics, PM&R, psychology, ophthalmology, and toxicology. And then there's non-clinical sites, including the Denver VA, where they do a non-clinical population health. They work at the Division of Workers' Compensation, OSHA and NIOSH. And then there's a big demand for occupational medicine physicians, and they go out, our residents, when they graduate, go out and practice either in public or private clinics. They sometimes, if they have specialty training such as pulmonary, additional pulmonary training, they'll practice in that field. There's a huge demand for corporate medical officers, not so much in Colorado, but across the country, other parts of the country. huge demand in academic training centers and positions go unfilled for quite a long time, and then in federal agencies. That's it. Hi, I'm Carolyn DiGiuseppe. I am preventive medicine trained, and I also trained before that in pediatrics. And I too am grateful to the Department of Family Medicine for welcoming us into their fold. So I thought a lot of people don't actually know what the specialty of preventive medicine and public health is. We like to think of ourselves as the physicians with populations as our patients. But I thought I would just show you a few slides from the American College of Preventive Medicine about some of the kinds of things that preventive medicine physicians may do in their practice. These should go automatically. Yes, there we go. So we have actually been a boarded medical specialty for a long time. We're one of the earlier ones that was boarded in 1948. These are the kinds of skills that we train our physicians to have, including particularly epidemiology and biostatistics, some environmental and occupational health, clinical preventive medicine practice, emergency preparedness, a lot of planning, administration, evaluation of health services and programs, and health policy and management. This is our basic training structure. In the first year, our residents generally only do a few rotations. They have 2 pretty extended rotations in the first year and 2 in the second. We do a lot of the training in the first year at the VA in clinical preventive medicine, in emergency preparedness, in research and quality improvement, public health practice at a public health agency. And in the second year, most of the time is spent at a primary practicum site. Those are quite varied. We have sites at Kaiser, Denver Health, and other places, and also elective rotation that might be at, I have one resident now who's in the Office of Disease Prevention and Health Promotion in Washington, D.C. We do other agencies here in Colorado and other organizations. We do some clinical practice at various clinics at the VA, at public health clinics, at occupational medicine clinics, and integrative medicine and others. Some primary care as well. Our residents, like occupational medicine, complete a Master of Public Health during the 2 years of training. Ours is in epidemiology rather than environmental health. So I didn't list all our program faculty because there's a lot of them and they come from a lot of different places. Some are preventive medicine physicians, but unlike family medicine and other specialties, you don't have to be a boarded preventive medicine physician. You just have to have appropriate qualifications. We have other physicians, we have public health practitioners, educators, researchers, and many others who are faculty. We have 3 or 4 residents in each year of training, so generally 6 to 8 residents. The requirement is that they've completed at least 1 year of ACGME accredited clinical training, preferably in primary care. So beyond that, it varies. We do get people who have completed that 1 year of training and they've always wanted to do public health and preventive medicine, and they come straight to us after their internship. We also get quite a few sort of second career clinicians who have finished their training and want something more, something different, something else from their practice. Some are like me. I finished pediatrics and went straight into preventive medicine. Others may have been out practicing for 10, 15, sometimes 20 years. They kind of want to maybe move to the 30,000-foot level. We do get some clinical residents who have trouble with the demands of training and in a clinical residency, particularly the high acuity hospitalists, and so hospital rotations, and we get some of those as well. So obviously we prefer numbers 1 and 2, but we do have very good residents who come to us because they feel that they need a different approach to medicine.
Our residents, about a quarter end up in a clinical medicine situation. Usually they're doing clinical medicine plus something else, like quality improvement, like Tom McKenzie at Denver Health would be a good example of that. Some go on and do ACMED, as Roxana mentioned. We have residents who go to nonprofits, public health agencies. We get some from the military, academic medicine, so a wide range. These are just some examples of some graduates in the last few years. Student health, Department of VA, Interministry Health Advisor, Regional Medical Director for Work Sites at Concentra, someone in academics, someone at the CDC, Global Health Consultant, and a Senior Policy Analyst. So a wide range of careers. And residents can, to some extent, structure their training to follow their career interests. So that's it.
Hi, I'm Dan Burke from the department. I'm going to talk about our rural training track that we're developing in Fort Morgan, Colorado. So, why are we doing this? We hope to improve the healthcare in rural Colorado. There's a couple of maldistributions in the physician workforce. One is there's probably not enough primary care physicians, and the other is there's probably not enough physicians in rural areas. There's probably other maldistributions, but those are the biggest. It's a way to increase the number of family docs. In 1997, there was a cap placed on the number of residency positions that Medicare, through the GME program, would fund. One of the exceptions to that was rural training tracks. So this is an avenue for increasing the percentage of physicians that are in family medicine. And the third is, I think, to improve family medicine training. I think that having a relationship with a rural training track, you can, residents in an urban program can get some experiences that they wouldn't otherwise get. So what are we producing? It is a rural training track that is approved through regulatory issues that adhere for both GME in the Medicare program, as well as that it is ACGME accredited. The importance of it being Medicare accredited is that we actually will get funding for the residents and hopefully a little bit left over to run the school, so to speak. So what is a rural training track? A rural training track is the same as a family medicine residency in that it is 3 years of training after medical school. It's different in that the resident spends the first year in an urban or central residency program and then spends the second and third year at the rural site. So what's the timing on this? Everybody says, well, when do we get our product, our first graduates? That won't be until, if everything stays on schedule, that won't be until June 2019. So that means that we would start our first residents in July of 2016. We're looking at trying to have 2 residents per year. July 2017 is when they would first show up in Fort Morgan as residents and then be trained for the following 2 years. In order to get to this point of July 2016, we have a considerable amount of work to do. So what we're aiming for is to submit our accreditation program information form by September, have this September coming, have a site visit in January. August, next August, we would find out, August 2015, we would find out whether we're accredited or not. If we are, then we could start recruiting students to come into the program. If we are successful, we would find out about that about a year from now in March, and then two years from now in March, and then start training in July of 2016. Who is involved in this? Kind of a lot of partners. Obviously, the Morgan County community. The A.F. Williams Foundation supports a number of things in the department, and they're very interested. They actually reside in Fort Morgan. The School of Medicine and our department. The residency itself, Linda Montgomery is the program director of that. Salud Family Health Center in Fort Morgan would be the clinical site, the outpatient clinical site, the continuity practice for the residents. Colorado Plains Medical Center would be the hospital, and then there's a whole lot of other partners involved. So when the program is up and running, Elias Hernandez would probably be the site program director. He's a clinician at the Salud Family Medicine Center. Mike Patterson is the CEO of Colorado Plains Medical Center. Linda Montgomery would be the program director responsible for the whole sort of show. Sean Thompson is from the Williams Family Foundation. He's a family physician in Fort Morgan. And he'll be intimately involved. And then for the planning committee to do the work that I outlined over the next year, next 18 months, Kent, Mark Deutschman, Tillman Farley, Melanie D. Herrera, and I work on sort of keeping the whole thing together. We're going to do a community outreach, community engagement project as part of this. Linda Zittelman, Jack Westfall work with High Plains Research Network. Robert McGranahan and Mark Ringel are also helping us out. They're faculty with the department. Mark is a family doc out on the Eastern Plains. And then the Commission on Family Medicine is actually facilitating this with a couple of projects elsewhere in the state. And so as a whole state, there are 3 projects going on, and we're all learning together with this. Did I go over? Okay.
So most of you are probably aware that the Memorial Health System in Colorado Springs joined the University of Colorado Health. And I can't exactly say what the legal structure of it is, but they're part of us. And so Memorial Hospital is a hospital that has not had graduate medical education programs, and that is what a virgin hospital is. So that means that actually they would qualify for graduate medical education funding. It actually has it's a 2-hospital system. The Memorial Hospital in the main Colorado Springs is 476 licensed beds. Memorial North in the Briargate area is 88 licensed beds. And with the cap, then it can qualify for funding for new programs, not just family medicine, but any program that the university chose to start there. So to start a new residency, you could build a building and hang a shingle and start a practice from scratch, and that would take a long time to build a patient population of a size to allow the residents to each see their 1,650 patients during their residency in their continuity clinic. So ideally, we would like to find an outpatient practice that would have an interest and a volume for being a residency practice and in teaching. And so Jenna Reichelt from the department is actually exploring a variety of opportunities in Colorado Springs, both from the residency side as well as medical student education opportunities. So some of the possible practices that we've looked at include Colorado Springs Health Partners, Mountain View Medical Group, Kaiser, private practices. Peak Vista has been spoken for, and actually the osteopathic program from Rocky Vista is actually going to start a family medicine residency with Peak Vista. So to start a residency, once the practice is identified, you plan for the location and the facility, meaning the layout of the clinic, identify a program director, coordinator, faculty, develop a curriculum, prepare a PIF, the program information form that gets submitted to the ACGME approval, recruit. You have to finish your 2nd and 3rd years at the same residency, so the most you can start with would be residents in the 1st and 2nd year, and it's all a piece of cake.
Good afternoon, everyone. I told my wife that I was going to give a 5-minute presentation on the fellowship program today. She laughed. A lot. We'll see. So in 2012, a group of us gathered from the department and from the residency to talk about the prospect of a new initiative that was being looked at across the country to experiment with residency programs in the format of having 4 years rather than 3. In that meeting, we decided that probably wasn't where we were headed, but we began to think about all the resources that were available at the department level that would allow us to offer additional training for residents that might be interested. And we came up with quite a list of possibilities for people to explore. And we had a group of residents who are entertaining the idea of additional studies to prepare for their careers. And I think, as I'll tell in a minute, this is becoming an increasing trend for our particular residency program. So it seemed like an opportunity to get things started. So the way we've designed this is that the folks that we call fellows in this program work half-time as clinicians and faculty in exchange for some dedicated learning time. Our first 2 fellows began in 2013-14, and I've just listed them here. Alexandra is working in Mark's rural OB fellowship program. It gives him the opportunity to have another funding source to be able to bring people to that program. Haley Ringwood is being underwritten by Denver Health, and she's working on a new effort to create a community health center leadership fellowship there. And we've also worked through the issues of job descriptions, salaries, and gotten some things ironed out about that. And so we got, I was not anticipating this, but we now have support from both the Denver Health System and from the Department of Family Medicine here, which I think is going to strengthen the program a lot. So it's actually gaining some momentum. We had 2 people here this year I just spoke of. I've got potentially 4 people interested now in the graduating class that's going on. And I think we have somebody interested in addiction medicine, which kind of lapses in that direction. And so, potentially 5 people of a 10 graduating class that are interested in some sort of fellowship opportunity at graduation. And these are the areas that they're going to be focusing in starting in July, August, September of 2014. Looking at the class that's going to graduate the year after, I now have 4 residents that are declaring they want to apply for sports medicine fellowships. I have 2 interested in OB fellowships. I have 2 interested, if we can work an arrangement with Colorado Public Health to work on an MPH style program. So that would be 8 out of the 10 people in that class that would be interested in fellowship opportunities. So it's really catching on, and I think what this will do is it will define the groups coming in will be people and talking to our folks who say, yeah, this fellowship idea is really terrific. Let's keep on doing that some more. And it also talks about some possibilities of maybe we can expand some of the existing fellowship programs since we have such a high level of interest. So we have a lot of questions to work through. Can we create opportunities for fellows to work elsewhere in the university? We have begun discussions with the School of Public Health over the possibility of an MPH targeted program. How many fellows can we support in any given year? Since we're basing this on people being able to work clinically, is there some sort of limit of how many people we can put out in the department's practices, and what is that number? Can we do it longer? When we're talking about the MPH option, it looks like that would take 2 years rather than 1. Currently, we're thinking in terms of 1 year. Could we extend it for 2? And are there other funding models that we could use? And the other thing that I think about is how this effort, which is really focused on the graduates of our program going on, should that be expanded to the other residency programs? We haven't answered that question, or how we might do that to Swedish and Rose. And how this works with the other existing fellowships. As you've heard, there are quite a few. How does this effort work in conjunction with those? So, I think we move on to questions.
Ye doubters that we were going to meet our time. So you can see that it takes a village to be able to put together all the different types of programs that we have. And you didn't hear about a lot of our programs that are doing a lot of interesting work as well. And so we could have this meeting go on for hours if we really wanted to cover everything. But we wanted to kind of go over some of the programs you may not actually have heard about or known about. So Colleen is actually going to serve as moderator, and we're going to do some question and answers.
That sounds good. You guys are awesome. Look at the time. We pushed and pushed and said you cannot spend more than 5 minutes apiece. And Linda's beeping there. So our goal here is not just to have a presentation, but to have a chance for conversation about what they just presented. Because this is a lot of new stuff, and figuring out how we integrate all of our GME programs into the other workings of the department is really important. So our goal here is to have that conversation. Jesse and Linda and Casey actually have microphones because we are putting this online. We want everybody to be able to hear the questions. So it will be very important that not only when you're doing a question, you have a microphone, but our answering people also have a microphone. Okay? So, questions about this. Brian, you can start. She took.
Okay. So this is actually a question maybe for John primarily, but maybe the others. It has to do with the investment that the department is making in these efforts, particularly around say the 4-year training or the fellowships. And there's this huge interest in fellowships that you described. When you look at outcomes and assessing the investment that the department is making, what outcome measures are you using for success, and/or what are your expectations for these graduates of the fellowships after they become so highly trained and leave our institution?
My first goal was met. I actually asked some people interested in doing it. I've kind of overdone that a bit, but that's going pretty well. I think all these people will want to end up working for us, so that may be considered a faculty pipeline. I hope that's not true, because we're going to have a hard time accommodating that year after year. But I think one way to look at the benefit of this is we may have people with special skills. I look to Kyle, who really sort of pioneered this effort, and is now taking on a faculty role and very involved in practice transformation. And I think there are other people, since we have people with these interests already, and they're kind of attaching themselves to that. I think that's one of these things. I really believe that these people will look at some leadership options, not just locally, but probably nationally eventually. It's going to take a while for that to play out, but I already see that in Kyle. I see that in Amy, who's going to do the same type of practice transformation effort in the coming year. And we already know from the standard fellowships, our residents that have gone on to do sports medicine, for example, have started faculty roles in other universities, are faculty for our programs now. And I think that's another example of what the benefit might be. I don't know beyond that. Maybe other people have thought about what the possible benefits would be.
I know as far as the Addiction Medicine Fellowship, we're really looking to train leaders in this field. There's just not a lot of addiction medicine specialists, and the need is vast, and that's what we're looking to. And by the time they finish with the fellowship, they should be fully prepared to take the certification exam in addiction medicine as well, and that's certainly one of my outcomes. And so I would hope that our fellows go on to really, I think as time goes on, think of all the addiction you see in your practice, the addiction treatment and assessment evaluation is going to take more and more place in primary care, and we need leaders in that field.
Mark, I can see you down there.
The fellowship idea is great. Being one person who's run fellowships, but it is really a prolongation of adolescence. And I'm wondering, or suggesting that the department take a greater role in looking back and getting people who know what they want to do out of medical school a year earlier. And maybe their 4 years encompasses the last year of medical school, so we can actually get people workforce without the prolonged adolescence.
Dan, you worked on this for a while. Do you want to respond?
Sure. Yep, I think that that's a great idea. Anyone want to work on it? That's your project, Mike. So, in our P4 project, there were a couple of programs that did this. In fact, Missouri has done this for years. Frank, were you affiliated with the program that used to do this? And so, yeah, I think it's a great idea for people who really know what they want to do. It takes some. There's always regulatory issues involved. Are they a student? Are they a resident? I think the Missouri program is a good template. What happens is the student is a student in the 4th year. They are given some expanded responsibilities, and the residency promises to pay them back their tuition if they stay in the program. So there's a little bit of monetary incentive. But if they don't finish, if they choose a different career, then they're on the hook for their 4th year tuition. So, like anything, it would be a lot of work around the logistics, around the accreditation, and then developing a curriculum, doing role definition, all those sorts of things. It gets a little difficult as to what their roles and responsibilities can be in the hospital, and even in the clinic, because a lot of how these things are funded evolve around the billing rules, how a note's written, what the supervision is. But none of it is undoable, and there are good templates out there to follow for this.
So, at the last Commission on Family Medicine meeting, Dean Krugman actually brought up this as something that should potentially be explored. Problem is he's leaving, we're going to get a new dean. But when I was actually chairing the Commission on Education for the AFP, we had a number of medical students on the commission. And at the time of the discussions about all in the match and how to deal with the international medical graduate issue, one of the thoughts was we'll maybe have 2 matches and try and push the U.S. grad match earlier. And the students said that a lot of their colleagues didn't decide that they actually wanted to be family physicians until they're into their 4th year. And so they did a bunch of core rotations, and it's not until they've actually experienced family medicine or family medicine sub-internship that it clicks for them that that's what they want to do. And so it would be needed for people that really know ahead of time what they want to do, and it wouldn't necessarily be for all comers.
I have 2 comments. I get to comment as the moderator. One is that ACGB doesn't like this idea because of regulatory issues. They've been very difficult to deal with, and our boards have not been very happy about it. However, the hope is that on this campus, starting this year, there is a pediatric pilot going on where they're taking students in their 4th year. So it can be done. It's a lot of work. Dan knows this. He tried really hard. But it does happen. So it's just how you structure it. And it turns out that getting electronic health records making everything a whole lot worse. Worse. As with many other things. It just makes it like, oh. Well, because the way they set up permissions as students versus residents is very different. And so in the olden days, a student could actually write an order and have it co-signed, and that's not legal under EMR kinds of things. So it's very bizarre. Any other comments about the healthcare stuff? Other questions? Linda? Yeah.
So just a couple things to keep this conversation going. I've been, is Allegra here? No Allegra. So Allegra and I have been talking about it because there's such an echo. Can you hear that? Okay, sorry. So we had many people who came to our match this year who were so directed along urban underserved. And we see an opportunity possibly in doing the 4th, having them come in the 4th year. So that's something that we started discussing with the CU Unite people. Also, I wanted to say that the 4th year fellowship that John's working on is not so much an extended adolescence. We get them in the hospital, they get to be attendings, they get to bill like attendings. So that's one of the benefits of the kind of fellowship that John's working on.
I just wanted to mention that there is recently a precedent for a 4-year combined family medicine, preventive medicine residency program. And that's something that would be also interesting to explore.
And do we still have accreditation? We used to be accredited to do this. Is it still there?
We used to have accreditation for preventive medicine, internal medicine. As far as I know, we've never.
Back in the olden days, we had both.
Okay, it was a long time ago. There was a period when it wasn't allowed anymore by ACGME, but there is now at least one program in family medicine combined at level, and that's something that would be explored.
So let me ask you guys, all of you along those lines, as we get more different programs, whether it's residency programs or fellowships within the department, how do we cross-pollinate among the different programs? How do we have the preventive medicine, the occupational medicine, the family medicine residents, how do we get them to interact with each other and to actually create something bigger than the pieces?
So the program directors actually come to a monthly meeting that I have of program directors, and they get to share their stories and learn from each other, but out of that conversation are discoveries of shared opportunities occur, and I think occupational medicine is exploring doing something at the A.F. Williams clinic, just the same as addiction medicine is doing the pain clinic there. And so I think conversations are ways, and connectivity are ways to actually do that, and so that's one form. If other people have other thoughts or ideas, then bringing those to any of us would also help to facilitate that.
I'll just say one thing real quick and hand it down. We do have capacity, and especially with our community sites for rotations for family practice residents, if they wanted to explore occupational medicine or at least get some experience before they might be asked to do it in their family practice later on. And we also have an occupational medicine lecture series that we do over the summer, which I think we would be we would welcome family practice residents to come to if it fit into their schedules. It's usually later in the afternoon over at National Jewish, and sometimes down at Defer Health. So there are some other ways in terms of didactics that we would be very happy to have family practice residents join us.
Dan, you wanted to comment?
I think for cross-pollination, it's the fellows and trainees themselves that will be the bumblebees carrying the pollen around. And I think we'll actually have to be more deliberate than inviting each other to each other's venues. I think we have to create a central venue like we're doing with the fourth year fellows in family medicine, and create a central curriculum. And so I think it will be, whether it's residents or fellows, it will be very important and beneficial if they're in the same room at the same time learning the same things. It's not so important that our departments cross-pollinate so much. We're already in our silos, we already have our careers. But if we can kind of engender something new, a new normal for collaboration, I think that would be where the success is.
Hi, Ellen. It looks like Don wants to be after that.
So this is just a follow-up to that question. Kent, you mentioned a little bit about how you get these very innovative programs and leaders into a clinic setting, because not only do we need to cross-pollinate academically, I think our clinics are really asking for these new leadership skills. So as fellows, and then continuing that on, how do we get these programs, or the skills people learn in these programs, into our own department's clinics, not just A.F. Williams?
Yeah, that's me. Do you want to answer that?
So we like to keep them all, so we realize you're the share.
I have a comment. I don't have an answer at all, but I have talked with Frank about the possibility of developing a rotation for our residents in family medicine, which would be, some primary care practice clinically, but mainly some of the kinds of activities our residents do, like research and quality improvement, that they could certainly do, and I would encourage doing in collaboration with the family medicine residents.
So that would be a way to share skills and experiences.
I think it's an interesting question, and I've often wondered why we couldn't, involve Park Meadows and Westminster in those practices a lot more. But then I think about the fact that part of what finances the residency program is that they're so productive. And I wonder if we start putting out a lot of learners, maybe at the fellowship level that would make a difference, but I wonder if that starts slowing down, it may actually be from a financial standpoint somewhat counterproductive in terms of keeping the revenue stream going that helps us top off what we don't manage to make because of the challenges of doing clinical work on top of the educational program that we have at AFLIMS. I know you may not agree, but I think that's one of the things I think about.
We're all going to get a new funding mechanism. Right. Tomorrow, right?
So a couple of limitations are the curricular requirements that the fellow has to meet, and so they're not really free to just sort of go everywhere. And the numbers of fellows is actually pretty small. As there are more fellows and graduates, there might be places in the community where these people end up going and maybe actually do some of that kind of work. But from a learner perspective, it's sort of keeping the reins on things to meet the core objective, which was to train these fellows. And so for Patty, she's actually been becoming a victim of her own success that we actually have to keep reins on. So the pain clinic that she's put in at 8 Williams, she's been requested to also do an internal medicine, and she doesn't have the capacity. The consultative liaison service that she's creating could be a full-time job for her. And so to be able to be available to do what she was hired to do and teach the fellow and that kind of thing, there are certain constraints based upon all that.
We're going to get to you in just a second, but I will say that our sports medicine fellow, up until this year, had been based at the Westminster Clinic. And John, that's gone pretty well, and I think it's impacted that clinic.
It has, and that's where it is really quite productive. Sports medicine, we've also had continuity clinics in the emergency room, which seems a little bizarre for continuity. And so that there really is an ability to cross programs. As Dan said, you really do need a structured direction where you're going. When I left it up to the fellows to decide what clinic they wanted to go in, they went wherever was most comfortable. And your goal is to create a sense of uncomfortableness through the entire fellowship so that they grow a whole lot more. And it's a generation we're in right now that really enjoys prolonged adolescence, which I think is perfect for me because I've been an adolescent pretty often.
Don.
Yeah, so I was just going to speak to the opportunities within research. Jody and I have had some conversations with Kent and John and Linda about both fellowship and residency opportunities, but I think we have one of the top research groups in family medicine, and particularly for the preventive medicine folks, to the extent that we could be available for mentorship and including folks on projects and that sort of thing. I think there would definitely be interest.
Do you want to pass that? We're going to have one question after David, so think about your question.
So is Larry Green in here? There he is. I want to channel Larry Green and ask a really high-level question. So all of these fourth-year opportunities really sound like opportunities to specialize. Does this in any way suggest that the value of a family physician as a generalist is in any way diminished?
No.
Thank you.
No, and in terms of this prolonged adolescence, the generalist role in the broad scope of family medicine is kind of only practiced in two places right now, academia and rural areas.
So for that reason, if anything, it probably preserves the scope a little bit more, to the degree that we make them work in the hospital, you call. But there's just so much work to be done to improve the healthcare system that we need people with skills in leadership, and specific skills to advance the ball. So they'll remain generalists as clinicians, as doctors, but there's just a lot of work to be done. So I don't see it as being conflicting.
Okay, we have time for one more question. Larry, you got to have a last chance.
I really have a question for you three. Now that you've been here so long, what are your reactions to being in the Department of Family Medicine? And is there something the rest of us can do to help you that you would like to ask for?
I'll wait and start.
Residents make my day, right now, to be honest with you, I'd love to see more family residents over at Cedar, getting trained in detox and addiction there. Right now, we're training mostly psychiatry residents, and in keeping with the philosophy that I strongly believe addiction belongs in primary care, and I'd love to see more residents. Julie.
I'm sorry, can I just respond for Patty? We'd love to have, I just want to respond for Patty and say that we would love to have an addiction specialist, a counselor, hopefully.
For the occupational medicine residency program, it's been a great experience to come over to the Department of Family Medicine and to the School of Medicine. We were previously housed wholly in the School of Public Health, and now having all the support of both the department and the School of Medicine has been great. In terms of going forward, I think just continuing to have the discussions about how we can have our residents interact with the family practice residents, family medicine residents, and how they can learn from each other, and how we can have more interdisciplinary communication. I think that would be great, and I look forward to that.
And I would probably mainly second what Roxana just said. This comes at a very opportune time for our program because we've just received quite large training grant from HRSA, which is about integration of preventive medicine and primary care. And so thinking about ways to develop that and training sites that sort of bring together the two specialties is part of what I'm hoping to do.
I want to thank everybody for coming and listening and participating in the